Print studies, as it's associated with worse visual outcomes as compared to the post-op endophthalmitis. This is because of associated traumatic damage to ocular structures, more virulent organisms that are associated with it, and also delayed diagnosis and treatment, which may be because of concomitant signs of inflammation associated with trauma. Risk factors for a post-operative endophthalmitis, the main factor is treatment delay. So primary repair should be done within 24 hours. It's known to reduce the risk of endophthalmitis. Presence of an intraocular foreign body, especially an organic foreign body, increases the risk. Lens rupture, which allows microorganisms access to the vitreous cavity. Nature of injury, organic matter, as already mentioned, associated with higher risk. An intraocular tissue prolapse associated with a higher risk. A high velocity explosive projectile is associated with a lower risk because of possible self-sterilization in these cases. And laceration or penetrating injury associated with a higher risk as compared to a blunt trauma, which causes a rupture. Timely diagnosis is crucial so that treatment can be initiated early. Certain clinical features following trauma which may lead us to suspect endophthalmitis would be pain out of proportion to the degree of trauma, any purulent exudate from the site of injury, severe antechamber inflammation with fibrin and hypopion, and vitritis with severe vitreous opacification, which can be made out on B scan and is another indicated. To establish a diagnosis, a specimen may be taken from the wound itself or the aqueous or vitreous. Vitreous sample especially is important, and biopsy with cutter is preferred as it yields a more reliable, better yield, and also gives a greater degree of control with less vitreoretinal traction. The sample is then sent for routine microbiological analysis as early as possible in a sterile container. Coming to the microorganisms, among the gram-positive, Staph epidermidis is the most common organism, as in post-operative endophthalmitis. This is because it's a common commensal. Also, it's associated with an infection which is relatively less virulent and more favorable prognosis. In contrast, Bacillus is another common organism in post-operative endophthalmitis, and Clostridium. These are abundant in soil and produce an extremely virulent infection, in contrast with rapid onset of clinical signs and symptoms, typically associated with a ring abscess early, and it progresses rapidly with progression of corneal haze. Among the gram-negative, Pseudomonas is the most common organism, again associated with a fulminant infection with rapid onset and progression. Fungi, Candida is the most common species, typically associated with a delayed onset of inflammation after injury, about 1 to 5 weeks, progresses slowly, and patient may come with only minor discomfort with signs which are worse than symptoms. Typically, an inflammatory mass can be seen in the vitreous cavity, which may be described as snowballs, fluff balls, or string of pearls appearance. Factors affecting visual prognosis. The most important factor is the severity of injury itself, which is decided by the ocular trauma score. The virulence of microorganisms, as already mentioned, Bacillus pseudomonas associated with a poorer prognosis, Staph epidermidis associated with a relatively better prognosis, whether timely diagnosis and treatment has been initiated. Ocular wound characteristics, a number of studies have shown a more posterior wound and a larger wound to be associated with a worse prognosis. An intraocular foreign body, which may induce structural damage, for example, a retinal tear. It may act as the nidus for infection, or it may also induce an inflammatory reaction when it's a metallic foreign body. So, as a prophylaxis following open globe injury, the importance of early and meticulous wound repair cannot be stressed more. Unlike the post-operative variety, in this post-traumatic endophthalmitis, broad-spectrum systemic antibiotics do have a role, and intravitreal antibiotics can also be given as prophylaxis when the delay has been when there's a delayed repair, there's a dirty wound, or intraocular foreign body is present. These are high-risk cases where one would prefer intravitreal antibiotics as well. Investigations, as Dr. Das has already stressed, CT scan is important to look for any foreign body. And B scan done after primary repair is done to look for associated features of trauma which may decide the prognosis and the surgical management in these cases. Once a diagnosis has been made, prompt treatment with empirical intravitreal antibiotics should be initiated early. Gram positive, we prefer intravitreal vancomycin as the primary agent, and intravitreal ceftazidime is the preferred agent for gram negative organisms. These are to be given in separate syringes as they tend to precipitate together. And further management is decided by the culture and sensitivity results. Intravitreal voriconazole these days is the main agent preferred for fungal endophthalmitis. Early vitrectomy in these cases is important because these are fulminant infections, so that an optimal visual and anatomical outcome can be attained. The absolute indications of early vitrectomy being coexisting retinal detachment, presence of an intraocular foreign body, a clinically severe infection, and of course when there's no improvement or clinically worsening infection, after 24 to 48 hours following intravitreal injection, go for an early vitrectomy. The vitrectomy helps by removal of microorganisms, toxins, and inflammatory debris, gives you an improved media clarity, eliminates the vitreous scaffold for traction. Now, vitrectomy in a post-traumatic endophthalmitis is especially challenging because of the first factor being hazy media. You often find corneal trauma, corneal wound, corneal haze, which makes visualization difficult. There may be inflammatory membranes and cataract. Other coexisting features of trauma, such as hypotony, makes the insertion of infusion cannula more difficult. Retinal choroidal detachment, intraocular hemorrhage may be present at various levels, intraocular foreign body, and there may be retinal or vitreous incarceration, which make vitrectomy more challenging in these cases. Also, these are often young patients with an absent PVD, and any attempt at PVD induction in these cases is associated with high risk of retinal breaks because of inflamed necrotic retina. This makes vitrectomy more challenging. Now, to stress how PVD makes a difference in these cases, this is a patient presented, elderly patient has already undergone cataract surgery, PVD is already presented following broomstick trauma with an endophthalmitis, and as we've done the anterior vitrectomy and core vitrectomy, you can already make out the disc and vessels. You can see that the retina is in a healthy shape. As you clear the peripheral vitrectomy, this patient grew staphylococcus on post-operative culture, and this patient achieved a good visual outcome as the underlying retina, as you can see, is healthy. Now, this is another patient of the other end of the spectrum, presented to us with late following endophthalmitis with a hypotenuse eye with an intraocular foreign body and retinal detachment, young patient, no PVD. So to visualize the infusion cannula, we have to use a 6 millimeter cannula in this case. As we separate the exudates from the retina, you can see that there's no PVD, and here we end up creating an iatrogenic retinal break because these yellow exudates are often difficult to differentiate from the underlying yellow necrotic detached retina. Now, PVD at the optic disc in this case could not be induced due to possible vitreous incarceration. So we're going around the optic disc to separate the vitreous exudates from the retinal surface with the help of suction from the cutter. And vitreous forceps was also used where the suction from the cutter was not adequate so as to separate the posterior hyaloid and the exudates from the retinal surface. Once the exudates have been cleared, we are able to lift up the foreign body after localization and remove it through a clear corneal incision. Then the peripheral vitreous exudates are cleared under direct visualization with the help of cutter. Retinal detachment is then drained through the iatrogenic break itself, and intravitreal antibiotics and silicone oil is injected. In spite of all these measures, this patient only achieved a visual acuity of hand movements post-operatively. Choice of tamponade in these cases, silicone oil is preferred because of its antimicrobial activity. It reduces the occurrence of post-operative hypotony and also provides an optically clear medium post-operatively, and also produces an enhanced effect of systemic antibiotics and steroids by compartmentalizing the aqueous. To summarize, post-traumatic endophthalmitis is a devastating complication of open globe injury. It's important to keep a high index of suspicion so that an early diagnosis and prompt management can be done. Prognosis depends on a variety of factors, as already mentioned. Vitrectomy in these cases is especially challenging. However, a good early and safe vitrectomy with intravitreal antibiotics can help salvage the eye in these difficult cases. These are my references. Thank you.